here with the ribbon. Okay. Good afternoon. Did you work this morning or did you worked? Where do you work at?
I work at Platte Valley Medical.
Okay. Do you work?
Yep, Central Nebraska Veterans Home.
Okay. Do you work?
I work at CHI as a phlebotomist.
Okay.
Traveling.
Traveling?
Primary Regional. I don't work in the hospital right now.
Okay. Bartender, right?
No, I work at CHS.
CHS.
It's like a co-op place.
Oh, okay.
Platte Valley Medical Group.
Okay. No? Okay. Okay, people. Good afternoon. And you're the Friday afternoon group, and I know you don't really want to be here on Friday afternoon. But we have a lot of activities, and our role is to put the icing on the cake, meaning that you have gone through Apple Farm, Nursing Judgment, Lifespan 1 series, and our role in lab is to, they're the cake mix, all the ingredients, and they make the cake, and we put the frosting on it. Now, how we look at clinicals is going beyond by putting the flowers and the decorations on the cake. So all of it is needed for us to make a good cake and get something out of it. Okay, calories. So you've already met me the other day, and we will try very hard to get to know you. And so when you come for the day, do pick out your name and put it at the table. Do pick out a poker chip so that we can place you at the right table. And so we've got 4 groups here. You're going to work with that person at your table, and then next week we'll put you into a different group. Depending on the poker chip that you pull. And so there's red, green, black, and blue. So, anyway, you've met me, and so you're going to meet Melissa today.
I'm Melissa. I've worked here at CCC for 7 years, teaching adjunct. Been a nurse for 12. My current role is full-time educator for med-surg unit over at Kearney Regional.
So she has a lot of experience. I've got more. But she's got more in the clinical setting. I've got more being a nurse as a nurse educator. Up there on the top is our name. You can call me Colleen. Probably if you call me Betty, I won't respond because I don't use that name. A lot of students call me Quad, just Quad. They know me sometimes as Mom Quad, because I'll listen to your woes. But look at that quad hammer. The other part of that is hammer, and I'm here to hammer some information into your brain, and so I have expectations. There's our phone numbers. Now, the problem with giving out our phone numbers, those are our cell phones, and we have another life. Melissa works at the hospital, at Regional Hospital, and I have another life too. I go to the gym when I'm not here on the mornings. I do DJing over the weekend on either a Friday or a Saturday at a wedding or a teen dance or something like that. And yeah, do I look like one that can get down and boogie? And I
DJ'd my wedding.
I DJ'd your wedding?
You did DJ like 3 years ago.
Woo-hoo! Did we do a good job?
You did.
Did we dance? Did we do the Cupid shuffle?
Yeah, I did.
So, thank you. So, if you are coming to class and you hit a deer, you better be calling us. We want to know if you're okay, and we want to know why you're late. But if there is something like, do I need to bring my stethoscope tomorrow to lab, that is something you can call each other about. to bring your stethoscope. You didn't talk about it. You bring your stethoscope. You don't need to call me for that. And you can bring it, and it's not gonna hurt anything if we don't use it, okay? So think about what do you need to call about, what do you not need to call about. Now, I'm saying that because eventually you'll get in a position that you are calling physicians. And I do know of a nurse that lost her job because she did a fantastic job, but when she got home, she said, oh, did I forget to do this? Oh, did I forget to tell you that? You know, those kind of things. And she was actually calling the physician after work, because she was working in a clinic, and it wasn't necessary. If it's a life and death matter, then you need to call us. But if it's something that can wait for a question to ask when you come to class, or ask another instructor, then do so, okay? So that's, I know some instructors do not give out their cell numbers just for that purpose, because they have another life. But Melissa and I do not have set office hours here. So you have to call us to talk to us if you need us for any reason. I have the sheet in front of me to tell me who's here and who's not here. So, because of only being in lab for 3 hours, we are going to go fast and furious. And so, again, we are doing activities so that you can really learn the stuff that we talked about or they talked about in class during the day. So, the very first thing is we're going to be talking about HIPAA. What does HIPAA mean? What does HIPAA stand for?
Health Insurance Portability Accountability Act.
Right. And so what's one word that you can use instead of that whole HIPAA definition? Privacy. So, the first activity is?
Write between 8 and 10 ways that HIPAA can be violated when you're at a healthcare setting.
So then,
On the board?
now usually one writes and the other one talks, and then when we do our next activity, yes, on the board. Then we'll switch. Okay? So 8 to 10 things that violate the HIPAA.
People who don't need to know. Or should I just talk about social media? Oh, yeah. That's a big one.
Smaller group.
I don't know, those are good. So, it's hard to figure them because there's so many. Record pictures. Pictures and to whoever, you know, the person that you're working with.
Yeah.
Driving a truck or someone else.
You're just like discussing too much information. Like being, you know, upfront, like, oh yeah, take these pills because you have, you know. Getting information.
What was it? Report, giving report.
Talking with other patients about other patients in the hospital. That's when it's probably over talking about patients in the hospital. I think I'm going to Columbus, or we're going to that one.
Video, you know, the faxes came in, just like, you didn't look like she had security. It didn't look like it was plugged in, but it wasn't.
Misplacing information. Like we turn in the wrong. Or put something in the wrong place on paper. As long as it's pretty much covered, it says it's so general.
Yeah.
Okay, one thing I should have gone over, before we get into this HIPAA thing is, what you're wearing for here. It looks like you all got the message. You either wear your uniform, you know, and when you're in uniform, yes, when we are doing activities in there, you're pulling your hair back and looking like a nurse. When you go to clinicals, make sure that you don't wear earrings and necklaces. I'm dressed in normal clothes. I have jewelry on, but my jewelry would scrape a baby, scrape a patient, especially an elderly patient where you barely look at them and the skin breaks down. So I would not be wearing my rings or my watches. It's kind of funny when I've been doing a lot with OBP, and my husband, and before that I was doing the surge, you know, and he even said, oh, you're not wearing your wedding ring, you must be in labor and delivery. So he even knew that I don't wear my ring when I go and do patient care with those babies. And I wouldn't wear them at all. Whereas in that church, I might wear my wedding ring, but I would be very careful, and sometimes even putting on gloves and touch on the wedding ring. My earrings, I have loose earrings now, but they are not a safe thing for babies to grab a hold of, or for me, because they're going to pull on it. And you say, well, I'm working with adults. Well, guess what? Adults sometimes aren't thinking right, and they can grab different parts of the body as well and hurt you. And necklaces, don't wear a necklace, not even a medical. Well, a medical alert necklace, yes, you have to wear that at all times. But a religious one, if you can take that off, take that off. Because babies can grab it, they can pull on it, they can put that finger in their mouth, and they swallow it in nothing time. But look at Melissa. She is going to be going to work. She doesn't have her earrings in with me today. Okay, no necklace. Fingernails. We are seeing a big concern with fingernails. And people, I had gels on my fingers and gels, and it was painted up and it was pretty, and I love it. But I went and had them removed, and the last time that somebody removed them, they used the file while, and now my nails are working like crazy. So it's really better as a nurse to you. Just let your nails grow out and take care of them. As far as shoes, you need to always have pretty good, stable shoes. Do yours have kind of netty stuff on it, or?
Kind of in the front, I guess.
The thing, and I know that they're not saying that you have to have white anymore, I guess. I'm old school and I think it should be white, but leather cleans up a lot better, especially when you have to walk through some of the stuff that you have to walk through. With your netty shoes, that they're fabric on top, just be very cognitive that you may have to clean them and really clean them well. And keep in mind, whatever you step into, if your pants are too long and happens a lot, you know, whether it's stool or emesis or blood or whatever, and you're walking through that and your dry is in the back of your pants through that, you're taking that home. Okay? And so, just a bit of advice, you know, really think about those kind of things as a nurse, because you don't want to give somebody else something, nor do you want to give your family something, or you don't want to get sick at all. So you can wear your uniform here, or you can wear a CCC t-shirt. So go ahead and stand up, Loretta. And she has a CCC t-shirt. If it says nursing, that's great, but they're kind of hard to find. But CCC, in other words, no Budweiser t-shirts. And there are some nursing jokes t-shirts that it's kind of, you know, if you want to be a nurse or funny, you know, funny things. That's not appropriate here. And there's different things that we're going to be saying because we're going to try to help you develop into that professional person. Okay, so if you have your uniform on and you go to Walmart and your uniform, your hair is down and you're not in full uniform, you got all these earrings in and all those kinds of things, people in the community will see you and they'll say, what kind of nurse she is. Well, it already shows on your name tag that you're from CCC. So when you think about being a professional in nursing, you have to think about how you present yourself. So basically, don't go to Walmart, even if you're out of uniform, with pajama bottoms on. You know, we've all seen that happen. And so, no pajama bottoms on, or lounge pants, because you're not lounging. You're going to the store. And somebody might recognize you and know that you are a nurse. And they think, oh man, look at her. She's wearing her pajamas here. So always try to be as professional as possible. And we're going to be giving you some clues along the way to make your job easier and make you feel more professional in the long run. Anything else that we were supposed to say? Okay, and also this is a safe place, meaning that if there is something that you have a question about, you ask it. We're not going to make fun of you. We're not going to let anybody else make fun of you, because if it's a question, it needs to be answered, okay? But we're always going to be very respectful of each other in this classroom, and if there's anything that has to do with pathogen or Farm, I taught pharmacology for 100 years here. Nursing judgment, taught that. Lifespan, I taught both basic nursing and med-surg for years and years and years. And I think between Melissa and I, we can help you with some information that you don't understand through the other classes. And so just ask. Just ask. And if we don't know the answer, we'll say we don't know, but we'll find out. Okay? So, any questions of us? Okay, and I hope that you'll have fun in this class as well. So, who should we start with? Melissa? That's who I was going to pick. So, put your big
taking pictures of the patient or information.
Talking about patient information with people that aren't supposed to, like, have no business with that patient. Social media, posting things about said patient. Taking
And we're
patient,
gonna be talking more about social media in just a minute, so.
like taking patient information, say we're on the floor and we get our little index cards and we take it home with us. That's a violation of HIPAA. Leaving patient information out and visible to the public. So if we have their paper chart and we just leave it there in the nursing or the lunchroom or wherever we're at. Getting into non-patient information. So someone like, oh, my best friend's there. I want to know how they're doing. Pull up their chart. Loud conversation. So say we're saying goodbye to them, but we may say, oh yeah, don't forget to take your antibiotic for this, for everyone to hear. Releasing too much information, like when you're talking to like a family member and they're not on the list to release information, you're saying, oh yeah, they're fine, they're coming back from rehab because of this injury, even though the family member didn't know. And getting into the wrong person's getting info to the wrong person. Like say over the phone, oh, I'm so-and-so's son, turns out it's not their son, that's, we can release information to, like, we can't verify that. And then misplacing information, like putting Dr. Jones's information into Mrs. Jones' information, they have no correlation with each other. Or just by mistakenly charting in something wrong from someone's information to another patient.
I go into panic mode when I'm a clinical instructor and I have lost my brain. Meaning that I have a list of the patient's name and I have a list of the students and when they're supposed to be giving medication, and I walk in and I help you do something and look at it while I was talking to the patient, and then I help you do something, fix the patient up, and I walk out of the room and my brain, my paperwork is still in there. I go in panic mode because I need to get back in there and I need to find that information, get it back in my pocket. Now for you guys, a lot of the students will get clipboards, and they're the nursing clipboards. And if you clip your information on them, those clipboards, just flopping them over, you're not really hiding everything. So I would flop over my papers onto that clipboard and then put the clipboard upside down. So it's a double protection. Some of you will get those clipboards that have the plastic, you open it up, and there's a container in there that you can put your papers and take care of them. We'll talk more about that in just a minute. So we should go around and see if anybody else brings stuff up. Okay, red guys, girls, ladies.
Sharing patient charts. So pretty much like the nurse's station or anything, you're just talking about it loudly.
Okay, talk so that this girl can hear you. Okay.
Throwing patient's info into the trash and not sugar. Talking loudly about patients at nursing station, going home and talking about it, leaving chart face up, leaving computer screens open for people to see, texting about it, grabbing a chart for a patient that's not yours, giving out patient information over the phone to someone that asked, and looking up your friend's charts.
Okay, we'll keep on going, and then I got some more stuff. Melissa and I have more stuff to say. We have talking about the patient.
Leaving a chart open, not closing the door, curtain, or for patient privacy. Posting pictures of patients on social media, giving out patient info that you're not supposed to give it to, yelling at a patient's name in an open area, giving patient information without the patient's consent, keeping records of patient's information that's not needed, so like going home with it or putting it in your pocket, and exposing patient info. Sure. So leaving the chart left open where people can see it, taking
without patient permission, sharing info with the nurse on a different unit about a patient, giving report in an open setting, fax machine in an unsecure area, so like leaving the papers out where people can see them. With family, or assessing patient with family present without patient consent. So you should ask them, is it okay if I information, or do I need to step out?
Okay, so, a couple different scenarios that I have seen in the past. I had a student heard that her boyfriend, how was it? Her best friend's ex-husband was in the hospital, and she heard his name brought up in report, and within minutes, she was texting on her phone telling her girlfriend that her ex-husband was in the hospital. Is that a HIPAA? Absolutely. You can't do that, okay? Another incident where a student went to a baby shower, okay? I happened to be at the same baby shower. And somebody said, oh, you see that we heard that you're in the nursing program. And she said, yes, I'm in the nursing program. And then they said, well, how do you like it? Oh, it was really exciting today. I had a patient that that had respiratory problems, ended up going to, we did this for him and this for him, and he went to ICU. She didn't say the patient's name. Was that a HIPAA violation? Yes. And it turned out the relative for this patient, and it really was a girl. It was a girl telling me it was about a girl. And the grandmother was sitting right next to me. And I didn't know that this was grandma to that girl, or she didn't even know that. And the student just kept on talking, but grandma was over here. Grandma didn't know that all this happened to her grandchild. HIPAA violation. So you say, well, I could go and say, yeah, I'm a student at CCC. And you could say, I'm learning a lot at CCC. And I've had lots of experience. That's it. Don't tell them that you had the experience of being able to go and get all these flu shots, but you will be doing it in the first part of October that we've got to get you ready for. Okay. You can't say what has happened to the patient. Now, I walked into a situation where I was going to go and get a new uniform, and the person that was running the uniform shop at that time was an old friend of mine. We had even worked together when I worked in OB, and she had worked in the nursery. We knew each other, and this, for years we had known each other. And so I walked in there, and we were talking, and she said, where were you today? And I said, I was at the hospital. And she said, what department? Because she knows that I've gone to every single department at the hospital. That's good, Sam, not a pharmacy. But I've gone to every single department. And I said, I was up in OB. That's all I said. But guess what? She knew what had happened in OB, that we had a delivery, and the delivery went bad, and the baby ended up going to NICU, and they didn't know if it was going to live or not. And she said, oh, I know what happened there, and so-and-so had a baby, and we were probably in on it, and the baby went to NICU. And all I said, I was up at the hospital in labor and delivery. So what I did was set myself up to a possible HIPAA violation. And instead, I said, how much is that pocket saver? I tried to stop that conversation completely. And she looked at me, and she knew exactly what I was doing, that I was not saying another word. And I didn't say yes, that we were involved in it. I didn't say no, we weren't involved in it. There was no names said, but I set myself up for a possible HIPAA violation. One thing that you guys got to do is not set yourself up for a HIPAA violation. Always be cognizant of that. Been in the hospital, and I know lots of people from a small town situation. And in my small town, I had a student that came in, and she cared for this patient. Then she went back to her job, and she was in a grocery store. And her patient that she had was now going through the line. And all she did was say to her, "How are you doing?" And the person behind her, small town, said, "Oh, what's wrong? Are you sick?" Because they knew that the cashier was a nursing student. And the way that she said, "How are you doing?" Anyway, this former patient of hers reported her to the CCC, and we had to have a discussion. What did you say? And she said, "I only said, how are you doing?" So, what could she have done? We didn't kick her out of the program because we didn't feel like that was a HIPAA violation. But she should have just said hi and kept on checking her out. Now, if that would have been a patient that wanted to talk about her illness, to say, "Oh, I'm so glad that you were in the hospital caring for me. You gave such nice care," then fine, hunky-dory. But this person did not want the whole town of Minden to know that she was in the hospital, and she especially didn't want the person that was behind her asking her questions that she was going to have difficulty in answering and didn't want to answer. So people, we have all been in a situation, all of us, as nurses, that it would be so easy to violate the HIPAA that we have to be very cognitive of what we say, how we say it. And I've had my parents, I had my cousin in the hospital, walked into the room. Last name was Smith, very easy, to think you're not even walking into somebody you know, and ended up caring for assigning my cousin to this, assigning a student to my cousin and didn't realize it. And he said no, he would keep that student. He has a right, and you have the right to say to the nurse manager, "This is my cousin, can you give me a different person to care for?" And that should probably be what happened, but my cousin said, "No, I want you in here." But I did not tell my parents or my siblings that he was in the hospital. And it was months later that my parents heard about it. And they came to me and said, "Why didn't you tell us? We would have thought us to visit him." No, I can't even recognize that he was in the hospital. So people, one thing that you've got to really watch for is sharing that information. Even as simple as it could be to say, "Hey, he's in the hospital, why don't you go up and visit him?" I can't even say that. Okay, I can't even let them know that he's in the hospital. Now, one of my mom's friends said to me, "I really wish your mom would come up and visit me." And I said, "Here's her phone number. I will not be telling her. If you want to call her, you can." And that's what she did. But I had nothing to do with conversing. Of course, when I saw my mom wanted to know all the details. And I couldn't give out all the details about what was going on with her friend. Now, another thing which is similar to HIPAA is called FERPA. And and FERPA is, privacy within an educational facility. So if your mom is upset with something that's going on, and she cannot call us and talk to us about your grade or those kind of things unless you put her down that she is a contact person for financial aid or something like that, okay? But we can't get that information. We can only say, yes, that person is enrolled in school. Now, taking HIPAA and FERPA, we've got Melissa over here and she works at Clay Regional. She may know what your grade is if you work over there, but she could be hit in trouble if she gave out grades. And by the way, even when we are your reference for getting a job when you get out of school, we don't give grades. We say that you completed the course, or and the big questions they ask for: what is their attitude? Do they want to? Are they dependable? Do they work well with others? And so even in here, people, we're watching you to see, are you working well with others? Because you're going to be switching around, and do you work with everyone well, or do you only work with the select few? Okay, so Melissa is kind of in a tough situation because she's a teacher, so she has to know her limits based on FERPA, but she is also a nurse, and she has to think about HIPAA. Now, as instructors, we will be bringing up cases, and you will be in clinical situations where you all know about Mr. Smith. And in that post-conference, you can all discuss Mr. Smith. And you might be doing your report on Mr. Smith. But what do you put into your report? First of all, you only put in you need to know to understand this disease process and to understand his treatment plan and how we respond to it. But you don't need to tell us that Mr. Smith is a cousin to Quadhammer and this is, they had a good report or a bad report. That's not necessary. Also, sometimes you will go home and you will be real frustrated and feel like crying. Every student nurse feels like crying sometimes. And it's whether you are upset with yourself for not knowing the procedure and not doing it well, you're tired and exhausted and you can't remember what your med is, and your instructor is saying, tell me what your med is. What are the side effects? And you're going, I don't remember. Okay, and then you go off to cry and say, wow, that instructor really harassed me for my meds. Yeah, that is one way for us to know that you're learning and you're putting things together is to quiz you. And it's not to intimidate you. It is not to harass you. It's to help you learn that stuff. So we will be talking about that. And you might be crying. But the thing is that you need to be able to talk about it. So look around here. These people are your support people. They are there. They understand what you're going through because they're going through it at the same time. Your husband or spouse or whatever, your kids, they don't have a clue. So they're no good. But instructors know what you're going through because we've been there too. Okay, now we want you to erase your board. And you brought up a lot of social media. When we talk about social media, what are we talking about? Facebook.
Snapchat.
Snapchat. Twitter. You know what? This president of ours doesn't have a clue what he should put on Twitter. myself in a heck of a lot of trouble by what he writes on Twitter, because when it goes out, it never, you can't ever take it back, okay? So Instagram, Twitter, Facebook, email, and sometimes I just think it's easier for me to call you up than the email. But what are the advantages and disadvantages? So within your little group, divide your thing into, and I want you to think of what's the advantages of social media in the healthcare field, and what is the disadvantage? We're going to be taking a break after we report this.
Perfect.
But if you really have to go, I hope it comes out okay.
You can get the new update. Yeah, like bring everything into the future. You can get new updates. You write that out. I'll figure out disadvantage. It's everywhere.
Well, at first because we just did it, and so you're like, did I say that this time, or did I say last time?
I keep something on the preview shot.
Well, we're going to have a little camera.
But it is, that's the thing, when you
Connection,
like comment.
yeah.
What do you think? So,
Quick communication. Miscommunication. Did you hear the new one out there right now? Apparently information causes OCD, ADHD. Yeah. I could not stop laughing.
Wait, so are chickenpox parties like a real thing?
Oh, what?
Chickenpox parties?
My mom did it too. My mom did it too as a kid, that's how I know it.
So we just like get together and
They ate one kid, I think I did, and you just like, you play with them, and then you get chicken and stuff. I'm dead serious. My mom did that to me.
that is crazy.
She thought it was better than me giving it a shot. She thought it, and that's why I really need to it since I got it and tried it. But now I don't think we have to have
Yeah.
But then I know there's some disadvantages to the shot too. It doesn't work for everyone. It's still good chicken. It's an adult. Everywhere. Miscommunication. Misleading. Because you can tell, you want to do more holistic care, you want to give to oils or instead of taking prescriptions, you can say, oh yeah, what little bark is like aspirin. Never goes away. You should put that on your list too, because if you ever need to find something, you never say. Usually I think to find. Not that helpful. They got to do all the generation. That's true. Updates. Or what do you call that? Tech savvy?
played for Kyle the last 2 years.
You can put that down because if you're good at technology, you can find anything on the internet, especially on social media.
And especially.
Absolutely. These are requirements for everything else. It's not for that.
Right.
We really have to think about how to write this.
Or the young one.
And on the flip side, we could be in this information. Yeah, anything. That's research. Yeah. Access to.
All right, let's go ahead and.
We kinda just did Facebook, I guess.
You what?
We kinda just did Facebook, I guess.
Okay.
Staying up to date with your friends, you know, like the shared memories come up, those are sometimes nice, like she said that, sometimes she'll get like, oh, like, or whatever, like if you shared something on that. There's a lot of funny videos, so you can get a good laugh in. Updates, the Kearney area exchange, and you can meet new people. Disadvantages are.
And you also say, why do you know that person? Why are you saying alike when you don't even put them together? It's crazy.
Sharing too much information, there's a lot of drama, and crap talk and bashing. I guess in our experience, like those mom groups or whatever, there's some people who are like, oh, well, this person commented on this, that you get something from a flu shot, so I'm not gonna listen to my doctor, now my kid's not getting vaccinated because of it. There's a lot of weirdos. Bad thing. To your page, I don't know if I'm wrong, I guess you did. Do you ever get like porn shared on your page randomly by somebody? Did that ever happen to anybody?
Yeah.
I'm too old for that.
And if it's on Facebook, it's true. Family drama, I guess, I don't know, my family's divorced, so I always go, why did your mom post this, and why do you say this to your mom and not me, and whatever. And then there's a lot of young kids on social media that are just nasty about a lot of things. And then for Snapchat, we just put news.
News.
Yeah.
There's a good reason why I'm not on it.
Nobody wants to be the Biden. No way. Okay.
So we have advantages if we stay in touch, convenient, so it's kind of sad, but sometimes for emergencies, it's easier to get a hold of someone on social media than to get their telephone. Easy access, it's fun. Our disadvantages though, it's too much info, drama, too convenient. Sometimes you just have people that can't put the phone down. Info always stays on social media, false information, and it's easy to get in trouble.
Yes. Okay,
Okay,
Black Creek.
Disadvantages inside of more like healthcare than
Okay,
just
that's
general
right.
life. So we did like advertising of services available at the facility, public notification of closure due to like inclement weather. Disadvantage is once it's out there, so you can't take it back, and then it's easy to overshare without intent to violate HIPAA. So if you posted, I have a hopped on and said, oh yeah, I saw you at the hospital and you had a horrible day, I thought, you know, like that way it's easy to get involved without meaning to.
Okay.
Sure. We did more medical. So we
Said for advantages, medical updates, you're always getting like the latest and greatest technology. It helps everyone stay connected and it offers quick communication. The research you can get from online is like pretty much unlimited. Like you have access to so much stuff now. It never goes away, so that's an advantage and a disadvantage because you can access it easily, but at the same time it's there forever. And then if you're tech savvy, you can really get places that like regular people can't in a way. And then there's an app for everything nowadays, so.
I put for disadvantage, HIPAA, anything pretty much you post on there is almost always a HIPAA violation. If it's about work, patient, or what you've done that day. It's everywhere. You can't get away from it. And I think that's a big point. I like to be away from social media. Miscommunication. You could hear one thing from one person or one source and then hear it from another, like vaccinations cause. I was telling her like OCD now and ADHD. When it's like, what's your research? And it's misleading. They could say, oh, new leading updates for x-rays. Now we just take a picture with our phone instead of radiation. It never goes away. So once you put something up there, it's there. And if you're a tech challenge, it is not your friend at all. And information overload. Some people get a little bit crazy. I just got diagnosed with this new disease. I'm gonna research the crap out of it, or they go to that med doctor, research symptoms, and next thing you know, you have typical cancers.
That is so true. It can be your friend, it can be your foe. So last night, we were both talking, because we were exhausted by the time we got done talking yesterday. And I went home and I sat down, I couldn't get the TV to work. I don't know what my husband did with the remote and all this stuff. And I was on Facebook for an hour. What a waste of time, because I just sat there, and I needed to kind of recoup. But there was stuff on there I really didn't care whether I read or not, but I read it anyway. And it is a good thing to keep family kind of in the group of what's going on. As instructors, we are not your friend on Facebook. Don't ask us to be your friend. After you graduate, then we can be your friend. But we do not want to be your friend right now. I think sometimes things get out of hand on Facebook. Like you said, you say a simple, I had a rough day at work. Oh my gosh, it can build from that to a point that somebody says, I hate working at that place, or I hate working as a floater, I hate, I think it's a terrible hospital or whatever. And we need to promote positive things and not negative things. And so sometimes in Facebook, we get ourselves in trouble. So with social media, I had a student who was up in labor and delivery, and I sent her back to NICU, and she got to care for a 2-pound baby. She had never held a 2-pound baby, so she took a picture, selfie, of herself and that baby. Is that okay? She never said who it was or anything. But she did say the comment, I've never held a 2-pound baby before. Is that good or bad?
Bad.
Bad, because anybody in this town could figure out who had a 2-pound baby and whose baby it was. And she did not ask the permission of the family. Okay. But what if the family took a picture of her holding that baby and put it on Facebook? Is that okay?
I wouldn't think
It
so.
might come back to bite you later on in life, people. So you can say, please don't put that on Facebook if they ask you to do that. Or why don't you just take a picture of your baby and not me? Because what if they say later on, something happened to that baby, and they said, yes, and I had a student nurse, and that's her, that's a picture of her, don't remember her name, but that's a picture of her. Had another student, had a very complicated wound with complicated, complex care to that wound. And so she didn't take a picture of the patient, but she pulled it up in her textbook and took a picture, and it looked almost identical to what that patient had going on, and took a picture of what she was doing for that wound. And her comment was, learned a lot, took care of a patient with this kind of disorder. And she posted it thinking that she could share that information with everybody else in her class so that they could learn from it. Is that good or bad?
Bad.
Bad. Bad. She could bring that information to her clinical group, and you can all learn from it and discuss it. But then it stops. You don't take it out of there. Okay? So she had posted that on Facebook, and her comment was, I didn't give any patient's name out. I didn't give out any of the other details. And it's not even a real picture of, it's not a picture of a real patient. It's just out of the textbook. But it's too close. So people, don't set yourself up to get potentially doing a HIPAA violation and getting in trouble for it. Always protect yourself. So
I will tell you, like, some people said things don't go away on social media. When we are hiring, I get brought into the hiring process a lot to find out, have you had this person as a student? Do you know them? And we go and look at your social media. We look at it to see what you're posting. And there's ways that we can have the guys in IT break past all of your guys' privacy stuff to get through so that we can see what's going on your guys' profiles. So be really careful what you're posting. Snapchats. People show me Snapchats all the time. And I don't know anybody. If they're not my friend, I don't know who they are. But maybe you're in a picture and you're doing things that are inappropriate, and I see that. We do a lot with that, and social media is huge with the hiring process.
So although Melissa can't say that you're an A or B or C student, because you posted this on social media, and you're interviewing somebody for a job, you can pull out the stuff that you have posted. And so if you have done a wet t-shirt contest, and it's apparent that you are half run, and you are holding up your liquor, you say, well, I'm not doing that during school time, but it's showing that you're not professional. So, and especially if you're doing a lot of that activity, or garbage mouth, putting garbage words out there, you are not representing the nursing profession really well. And that could either, one, cost you a job, or you don't get the job. So.
And we use social media to affirm things to get people to be fired from jobs as well. So just be really careful what you're posting. Like Colleen said, Colleen and I are friends on Facebook. I post pictures of my son. That's pretty well all I post on Facebook.
I get the grandkid. So, yeah. Or if we've gone on a trip or something like that. So, I did post once that I wish I could take it away. And one of the things I tell the students, you gotta do this, you gotta do that, And I said, put on your good, big girl panties and just do it, you know. Well, I've been known to say that in class. And I had a student that graduated, and she had been gone a long time, and I was friends with her on Facebook, and she said, "Here you go, Mom, I'm quiet." And it said, pull up your big girl panties and just do it, but make sure you don't show your ass. And I put a happy, you know, like I was laughing, and said, "Yep, that's what I told you." And no, then I look bad for using the word ass. Okay? So it's something to always be cognitive of, and I wish I could have taken that test down. But better off, I shouldn't have responded to it at all. Okay? It was her joke, not me saying it. But I do believe that sometimes you're going to feel like, oh, why do we have to do this? Why do we have to do that? Why do we have to do this care plan? And I said, just pull up your big girl panties and do it. So I will say that. Take a break, and we will come back and have another learning experience. You can see that it's Friday because both of us are getting meaner. So take a break, quick break.
When do you want us back?
You only have 10-minute break, and that you 10 minutes. Because we gotta go. Chop, chop. Where are you from?
I'm from Lincoln originally, but I've lived in Kearney for 7 years.
Good. Mackenzie, where are you from?
Elm Creek, but now Kearney. I moved here probably 4 months ago.
You graduated from Elm Creek
Yep, in 17.
in 17. Not that long ago.
No.
Yeah, you're young.
Yeah, haven't quit school yet, so. Come on,
Oh, you're 20. You are young. Yes.
26.
She'll be 2 in October. Oh, what daycare?
Where's she gonna do?
Okay, what have we got next? I think. Charcoal.
Our kids go to pumpkin patch. We did like the whole animal thing. It was just too hard.
Yeah.
Because they take off so much.
Well, she did go to pumpkin patch, but they're not open till 6, and I started open till 6.
I love pumpkin patch.
Hold on to what?
I'm not looking at it. It's more expensive.
Yeah.
Oh, expensive.
You're welcome.
So do you have kids?
3.
3 kids?
Yep. Yep. I have 5-year-old, a 2-year-old, and a 10-week-old. 3 girls.
Girl.
Busy.
And then you said you were related to
I
Cindy?
know.
That's my mom.
Cindy Austin? Really?
Yeah.
Yep. I know, I'm like, kid.
And then I worked with her.
Okay.
One
little sheet? Okay, and she has one too.
I think she's missing.
I'm gonna go make some toys.
Oh, she's missing.
She went to
Okay.
make a copy.
I'll have to ask her. Norma Lucas? I'm actually marrying her next
Schroeder? So Jennifer's? Which one?
Josh?
Josh. Well, because Jeremy, who's the oldest?
John.
John.
John and then Jared and Josh.
John, and then Jared, and then Josh.
Yep.
When are you getting married?
Well, I wanna do it first, because I really like one focus. 'Cause we got engaged almost 2 years ago. I got accepted in the program.
We know the whole family.
Oh, see, everybody.
Jennifer actually babysat my kids for a summer or semester or something.
Oh, really?
And then when she went back to work, then we had to find a new babysitter or something like that. So, yeah, we know Jennifer. And, Jim works on our cars all the time.
Yep.
Well, because he's on the state wrestling.
And I taught Norma. She actually worked for us.
That's what she did.
So,
Their grandma still lived in hospital.
yeah. 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 She's still in, Norma's still in California, right?
She's in Colorado. She moved to Colorado.
After her second husband, right?
They went to see last year, one of them went to see last year. And they're black, right?
Yep.
Oh, yeah, I know the family. And I almost.
Oh, really? It was
I knew her too. I'm gonna move you to this
perfect.
next table for our next activity.
Sounds good.
But you'll come back. So just take your brains.
Okay, just to erase them away. Do you want me to take these papers to erase?
I'm moving her over there and you're moving over there. Wait a minute. Your name is Emily. We're moving Emily over. I was gonna try to think of it myself.
So yummy. It saved my life. Sorry.
What'd you say?
What?
What's up?
I think this is so cute. I didn't write it, but.
Okay, before we go on to the next one in communication, I do want to say something about Facebook. I actually know a girl that worked at the hospital, and she was constantly looking at her Facebook, and saying like, or don't like, or, comment. She lost her job because people could trace it back that she was on Facebook when she was supposed to be working. So the rule that they'll probably instructor probably will have a phone on her at all times because they are receiving phone calls from other students and they shouldn't, other students, but maybe that there is a notice coming out from CCC or they want to make sure that you were there, you know, and get you started or whatever the case may be. And sometimes the staff will even call. And when I've been on PEDS and OB, I carried my phone because I had students down in OB and they needed me to come from PEDS to go to OB and so on. So it was a means of communication. Phones are terrific because you can get a lot of information off of it. So you have a patient that you haven't heard this diagnosis, go to your book bag, pull out your phone and take a look and look it up because maybe you don't have the right book. Maybe you need to know about this medication before you go and give it right away, and it's quick and easy. But then stash that phone back into your book bag and leave it there. And the only times you can pull it out is if you are needing to get in touch with the instructor or needing some information or you're taking a break, you can get on to your phone. And your instructor may give different rules than that, but you're not looking at your phone when you're caring for patients, okay? So keep it in your book bag so it's not a temptation to even use. And like I said, that one girl, they traced her back and fired her. Okay, but we already mentioned that social media has the advantage of being able to communicate information from one person to another. In the hospital, you are required to give continuity of care, which means you will receive report from the girls that are the nurses that are going off duty, and then in return, you will give report when you leave as well. And you also need to find out who's the primary care nurse and keep in contact with that primary care nurse very closely. So there is a thing that we call bedside report where you will listen to report from the outgoing nurse right there at the bedside. So things that for example, dressing change or what needs to be done with the patient or whatever is discussed right there from the outgoing and incoming nurses and the patient and sometimes the patient family. But then that brings us to the point that you have to make sure that you communicate what is going on with that patient as well as what needs to be done. And that is called charting and documentation. And I think that they've already talked to you about some of the charting expectations. You may be in a facility that is doing paper charting, especially if you're in a nursing home. But most of the places are now going to computer charting. But the same rules go for both. And so we're going to go over some of the do's and don'ts of charting. And you have to think about applying this to your computer charting as well. Now, one of the things you're going to learn in computer charting, that at the hospital there is a recall button. Do not rely on that recall button to do your charting. When I've seen a nurse go, recall, enter, recall, enter, recall, enter, because they were in a hurry. And so basically they were recalling everything that the night nurse had said and putting it in as their charting. People, that's a real no-no. Now, if you want to recall because you think that the IV is a 14 catheter and it was a 16 instead, you can recall that and said, yeah, that's right. Okay, so sometimes seeing what they charted kind of helps you know what you need to be looking at. But your charting is your charting. You have to verify that this is for that patient, and during the time that you care for them, that these are the things that occurred. So this is documentation, do's and don'ts, and I'm gonna try to pull up how that affects your computer. Do read the nurse's notes on the patient before caring for him and before charting your care. You will get a patient profile, which is information about your patient. You will get that from your instructor. And from that, I would say use your highlighter and highlight information that is really important to know, okay? Or highlight things that you need to do. And especially at CHI, when the students are charting, I say to highlight the areas where it says to chart, so that you can go back through at the end of the day and make sure that you have charted it on all the screens. Otherwise, you're going to miss the screen. But do take a look at that profile and know what's going on with your patient. And if it says something that you do not understand, like it says it's IF every hour while away, and you haven't been in the respiratory unit yet, and you didn't know that that stands for a set of spirometer, then you need to be looking that up or questioning your instructor. The first resource is your resource, which is looking it up. If there is something that you can't find, then your next resource is your instructor. It is not your friend that's sitting across the table from you, because she shouldn't have to do all your work for you, okay? And the instructors shouldn't have to either. So you look it up first, okay? So know what's going on with that patient. Now that patient profile, though, is going to help you through the day giving that patient care. But at the end of the day, you need to put it into the bin to be shredded. Now, you will be doing paperwork. You might be doing a care plan. You might be doing a report to your group of friends here. And so, yes, there are some information that you need to take home so that you can look it up and study it and utilize that information when you give the report to the group in general. What you can do is with your paper, you can, your own notebook paper, take notes down. But you never, ever, ever run a copy of the chart on the copier machine. Like, for example, the labs, because you didn't have time to look all the labs up. Well, you cannot take a copy of it. You can write down things, you know, but only clues. If you are looking at the doctor's write-up for what they did in surgery, you cannot write that up word for word on your piece of paper. You can jot down notes so that you can refer to it when you're doing your report later on. And you cannot write your patient's name on that chart or that piece of paper. Because if you're in a car accident and your book bag went flying and your papers went flying, that information is a HIPAA violation. So you need to make sure that you are keeping everything confidential. Okay, any questions about that? Lots of times we do a code, you know, and I do a code by initials, half of the room number, you know, not the whole room number. You maybe scribble in the age of the patient too, and you get this thing that you don't know if it's what it is, if somebody found it. So, but do know what's going on with your patient before you start carrying them. Do have the patient's name and hospital number on every sheet. Now that has to do with you have a hard copy chart. And what happens is that we actually, even though we have the computer, we have the hard copy chart. And so maybe they've already done the lab and a hard copy of the labs come up. They come up with a whole bunch of patients together, and we have to make sure that we put the right copy into the paper chart. So take a look if you're ever looking in there to make sure that all of them have the same name up in the corner for that patient. When you are charting anything, whether it's on long nurses notes, make sure that you spell right and you have the correct grammar and you're concise. So you need to be complete and concise, which means we don't write long sentences. We just tell the facts and move on to the next facts. But you also need to be organized. So you don't start with the vital signs and say something about the lung, and then talk about the abdomen, and talk about the IV, and now you're down here and you say the patient's on oxygen. Well, where does that need to go? If they're on oxygen, it should be up there with your assessment for their respiratory rate and their lung sounds. So really be organized when you're doing any charting. And people, eventually you are going to be doing a summary, shift summary. And even though it's not long nurses notes, it's still a summary of what you did with the patient. Not how you did it, but how the patient tolerated. So you don't chart, gave patient a bed bath, ambulated in hallway. What you want to say instead is, complete, say, shower with standby assistant. Because you're telling about the patient, not what you feel about it, but how they tolerated it. And when you chart, you never say he, she, any, wells, and I'm missing something. Okay, I'll think of it. But don't say ambulates well, because well doesn't tell me anything. But they ambulates without dyspnea, difficulty with breathing. They ambulates with standby assist. Ambulates with walker becomes short of breath. Okay? Ambulates with oxygen on at all times, no shortness of breath noted. Okay, are you with me? So you don't ever say good, they did it good, they did it well, because that doesn't tell me anything. Same way with when you're charting amounts, you never chart small, moderate, or large. You need to actually give me a measurement. For example, in OB, with that peri pad on that woman, I need to say moderate, half of peri pad saturated, changes pad every 2 hours, versus complete saturation of peri pad in 15 minutes. Well, everybody and their dog knows that, oh my gosh, she is breathing a lot. Okay, are you with me? So you've got to give the measurable amount and not just always say large or moderate or small. Okay, so although they do have that on the computer charting for peri pads. Sorry. But then they also have kind of a diagram that shows you this is large, this is small, this is moderate. Okay, and you go by that. Make entries in consecutive order. Always do the date and time of the entry and use AM and PM in military. Instead of using AM and PM, you are using military time up at the hospital. And that says AM or PM, but we use military time, so you don't need the AM and PM. And be complete in your charting. So up here in the corner, when we're charting, and it could be a procedure, but we used a medication, we put down the time, the medication, or it could be a procedure. But with this medication, I gotta tell the full story. I can't just say Demerol given for pain. I need to tell the whole story. I need to say when I gave it, what it was, the medication, what is the dose, the amount, what is the route, how did I give it, and why did I give it. And then I need to be even more specific than that. So, 800, general, 25 milligrams, IM, 4 complaints of, and this is appropriate abbreviation, complaints of, do not need to have an of at the end of this. And I've seen students do that, of. So complaints of abdominal pain. But that's not good enough for me. Because I need to tell the whole story. So I need to say lower abdominal pain, or it could be incisional pain, abdominal incisional pain, rated at an 8 out of 10, which means he's having a lot of pain. And then later on this list, it says tell what the outcome is of what you have done. And so the outcome is within 60 minutes, you need to reassess that patient's pain. So at 8:50, I said reports relief of from medication, rates pain at a 3 out of 5 or 3 out of 10. Okay, so always do the response. Now I use the word reports, the patient reports, and there's a time when you will use states, the word states. If you use the word states, you have to do what they said, exactly how they said it, and put it in quote marks. Now there is sometimes that we want to have that. For example, I just want to die. I want to have that in quotes, because that's exactly how they said it. But there's times that we want to alter what they say and not quite what they said on the chart. For example, you are going in there to give them a Ducalox suppository to have a bowel movement. And the patient says, and I can say that here, I will not say it in the chart, I had the shit. I don't want that. I had the shit. Okay, I would not put that in the chart, but I would say refuses Ducalox suppository related to having diarrheal stools. But diarrhea stools to you might be just loosey-goosey, and diarrhea stools to you is that you've been in the bathroom 4 times in the last hour and having watery stools. So, as a nurse, I need to be more concise, and I need to say it that patient refuses Ducalox suppositories because related to 4 liquid stools in the past hour. Okay, are you all with me with that? So states, quotes, quote marks, exactly like the patient had, says it. Reports, you can alter it a little bit, but mean the same stuff.
So it's kind of our call what we want to put in there. Like obviously, like since that one was so abrupt, I had the shits. So it's kind of our call what to put in space for the patient.
I would not put that in my chart. I just wouldn't. So my call is, as a professional, that at this time I'm going to put reports. But if this patient is suicidal, I am going to say exactly what he said. And put it in quote marks. I'm going to kill myself. Okay. Do sign every entry using your professional signature. And so that is your first initial, last name, and SN for student nurse after it. Okay. Indicate, the next one, do indicate that the patient's non-compliance. Do use direct patient quotes when appropriate. So see, you were saying it's our discretion. It's when appropriate. that you need to have that information right there. Okay. Use the patient, the hospital's abbreviation. C/O complaints is an acceptable one. But we had a physician put in there FLK. And everybody was like, well, what does FLK stand for? And he wanted it to be funny looking kid. You know, and so that was not an acceptable abbreviation. He should have wrote it out or used different words. Document your nursing actions taken following indication of the need of action. It kind of goes with that meant. Do continue documentation of the problem until resolution. So if this person said within at 8:50 that he continues to have severe pain, rating it at a 7, so it only went from 8 to 7, then you need to follow up on it and say what you did for that then. Repositioned, gave back massage, diversional activity until that has gone down to a tolerable amount. We are not, we can't make a person be completely pain-free. And I hope you don't try to make the person completely pain-free because that's called death. So, but you do make it so that it is tolerable. And so they need to, you know, they have surgery, they have an incision, yeah, you're going to feel it. But is it tolerable? Can you still get up and move? Can you still eat? Can you, can you tolerate it? Okay. It says, do document all physician contacts. So you contacted the physician. Dr. Smith notified a patient's increasing abdominal pain. Orders received. Now, what if the doc didn't order anything? Then you say, notified Dr. Smith of increasing abdominal pain. No new orders received. Okay? So cover yourself with that. Also, along with this, and I forgot to talk about that, is that you always have to be on a good time frame. So, when you give this Demerol, which might make this patient drowsy, okay, if you do not charge Cybrel's up, call light in position, bed in low position, call light in place, and they fail, guess what? You're going to be sued. Okay? But if you forgot, you already wrote this down, or you put it into the computer already, okay? That computer documents the time that you went in there. Documents the time that you go in there to make your statement, and you need to alter the time. But let's say at 9 o'clock, he got out of bed by himself, and he fell and broke his hip. You cannot go back in there after 9 o'clock and say, oh, but I did put up the side rail, and I did put the bed in low position and give him his call light. If you didn't chart it up here, it didn't happen. And charting it down here is no good because the breaking of the hip already happened. Are you with me? So make sure that you think of all things that may occur. So you need to make sure that you say that, call like the safety issues, what you did about it, and everybody can see that you charted it maybe at 8:15, but they saw that you charted that you put the side rails up. And then when he falls over here down at 9 o'clock, it fell because he got through your side rails and was going on his own and slipped and fell and broke the hip. Okay. With that fall, then you have to do an incident report. Never, ever, ever put it in your charting note that an incident report was completed, because that is saying, hey, sue me, red flag. Let them find it out themselves. You know, you don't put the incident, your incident report is a communication within the facility that something happened that shouldn't have happened. And let's fix it. It shouldn't be, red flag, lawyer, come get this case. Okay? So, back on here, document the patient's teaching that you did, but it's real important not to say, taught in self-injection of insulin. No, that's your job. You're not charting about your job. But what you should instead is return demonstration of insulin injection procedure, appropriate technique by not doctor, but by the patient, appropriate return demonstration with appropriate technique. Sometimes it gets jumbled up in there, people, and so I gotta get it pulled out. But you have to say how the patient tolerated that procedure, you know, that teaching that you did. Now, if the patient doesn't do well in giving themselves their self-administration of their insulin, then you need to say reinforcement is needed. So that everybody else, the next nurse says, oh, we're gonna do this again. We're not just going to send you home and expect you to get your insulin by yourself. We need to work on it before you can be sent home. Okay. Use only the hospital-approved forms and charting. And so you guys are going to be going from over your education to Kearney Regional, and you're going to be going back to CHI or vice versa or something. You're going to go to different facilities, and they all have their own chart forms and their own expectations. But keep in mind what I said the other day. A hospital is a hospital is a hospital, or a facility, care facility. It's the same. They might have a little bit different in their paperwork. Adapt to it, but good patient care is good patient care no matter where you go. Okay, and if you are writing on paper, usually they say black writing because that's the only one that will show up when they photocopy it for orders or whatever the case may be. They don't use red and green, and I remember the day that we had 3 shifts, and so we had a black ink for day shift and green ink for black for days, green for evening, and red for night shift. And so that's how they could tell what shift it occurred on with our paper charting. So under the don't begin charting until you have checked the names. Make sure. And it always happens that there will be 5 patients on the floor, and all of them have the same initials, like B, J, and so their name is Bob Johnson and Bernice Jones. And so really take a look and make sure you match up the name. Don't pull a chart by room number only. If you do say, okay, this is it, this is their room number, then make sure you look at the name. And I've seen doctors do that. They pull the chart, they start writing the orders, and it was the wrong patient, because they do get moved sometime. Don't backdate or tamper or add what was written previously. And if you do make a mistake, like it should have been the left arm instead of the right arm that you're talking about, put a line through it. Do not scribble through it. Put one line through it. Write the word air and your initials before you write the right word. Okay? Do not write any in the margin if you're doing a paper, and when would you do a paper? We got the computer charts at County Regional and Good Sam. Well, sometimes the computers go down, and you as a student, you're not going to stay until they get it back up at 5 o'clock in the evening. And so you had to write out a paper chart to put into their charting because of that. Don't write something that's too general, like the wound is healing. You can describe the wound. So you describe it that there is no drainage, that the edges are deep, and there's no redness past an inch around the wound. And that's, you know, if it's not healing, you've got redness beyond the edges of the wound extending 5 inches. You know, you've got drainage that's foul smelling. So tell me what it looks like. Whenever you describe anything, describe it 3 ways. Describe it 3 ways. Skin, warm, pink, so the color, and intact. There's no open area. Urine, color, amount, and consistency. Stools, color, amount, and odor. Okay? Because there's times when you know that they've got blood in it, even though you can't see it, by the odor of the stools. Okay? Don't use medical terms unless you know what their meanings are. Don't wait till the end of the shift to chart because you always forget something. So chart along. And people, get your vital signs and your head to toe assessment into that chart as soon as possible. The doctors are making rounds at 8:30 to about 9 o'clock or 8 to 9. And they get real grumpy if they have to find you and you're down in coffee and you didn't put your chart in, your head to toe assessment 5 or 20 chart. Woo hoo hoo. That makes them mad, that makes us mad as instructors. Don't chart for anybody else. Now, if the 2 of you are in that room and you're boosting the patient up or something and you're charting, you can chart, you know, the 2 of you are in there. But if she goes in to get this Demerol and you had nothing to do with it, do not chart it. Okay? Do not chart it. That's their responsibility. Don't skip lines if you're doing the paper charting, and that leaves lines for people to come in and write in between you, and that's not good. Always sign your name, and never say something that could get you in trouble, like the patient is fat. You know, you may say patient is 4 feet and weight is 300. Okay, so you're describing what's going on with this patient, but you don't want to say something that could get you in trouble for it. Okay, so I think I went through that. You're up.
We're gonna go over SBAR and the I shape. I know Kearney Regional uses SBAR, and I believe Fulton does. The I shape, if you're going to Good Sam, that's what you're going to use over there for communication. We're gonna go over SBAR first. So before calling a physician, make sure you have all your ducks in a row. Make sure that you have done a thorough assessment of your patient. If you call the doctor and you say that they're having pain, but you really didn't assess them, your aide told you that they're having pain in their leg, you didn't go in there and assess them, they're going to be quite angry at you when you call. Review the chart for the appropriate physician to call. Out at Kearney Regional, and I know that they do it up at Good Sam too, they'll have a surgeon taking care of them, like an orthopedic surgeon taking care of them, did a total knee, but the hospitalist will oversee their care. If you call an orthopedic surgeon and say, the patient's blood pressure has gone up, blah, 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 they're going to say, I don't know. I don't care, and I don't know. They just don't. Make sure that you're calling the appropriate person that needs to be contacted for their care. know why they're there.
I've actually heard nurses say, I don't know why they're here. You should know why they're here, because you've been taking care
For
of
them. Read the most recent physician notes. The reason for that is if I'm calling
in the middle of the night, and
I get a hold of an on-call physician, he's
I have no idea who the patient is, what the plan is, what the physician has been doing with them. So we want to make sure that we can let them know
what's
what's
been going on with them. Have all your allergies,
medications, any pertinent lab information ready to go as well.
then you're gonna start with your SVAR.
So as the situation, so they're gonna wanna know who you are and who you're calling about.
If it is a serious problem, make sure that they know that. They're human,
Just like we are, and if you're calling
them in the middle of the night, and they're sleeping, they may not catch how urgent
it is, in
your
your
voice, so tell them that this is a serious problem. B is background. So tell why
the patient, is in the hospital, give your vital signs, give the reason that you're calling to
the physician. A is assessment, so this is what you're going to tell
him, how you assess the patient, what the situation is, how severe it is, and if it's
life-threatening. We need to really be letting them know that. R is recommendation, and this is really a tough one. In one of our last groups, you know, some of them may be really easy. You know, like, can I get an order for O2 if you have a patient that comes in and their oxygen's 84? It may be something very simple that you need, and you know what you need. And other times, I mean, I've been a nurse for 12 years, and I will be like, I have no idea.
I don't know what's going on. All I know is that there's something
Something is
not adding up here. So recommendation is telling them what you think they need.
I worked hospice for 3 or 4 years. I will tell you that family practice physicians are really not great with dosing morphine for patients. And when I would call, I would tell them that I would like an order to titrate morphine to comfort. And they would give me that because they don't know what an appropriate dose for a patient that's on hospice should be. Then make sure that you document that you contacted the physician. The I-shaped is very similar to SR, except for they have a few more things. The first part is they use AIDIT, and so this is like introducing yourself to the patient, telling them what you're going to be there doing with them, how long it's going to take, and then the thank you when you leave, you know, telling them, thanks for letting me take care of you. S and H are kind of the S of SVAR, so historian history. We're going to go over what's, yeah.
I need to get one of the CHI ones.
I'll get one. Historian history, so like their diagnosis. Okay. Past medical history, allergies that they have. Assessment, so the assessment that you've done on your patient. P is plan, so that would be your R of SR. What do you want to see happen for your patient? E is air prevention, so high-risk medications or other risk assessment things that may be going on. There's CWA in there, and if you don't know what a CWA protocol is, it's for patients that are withdrawing from drugs or alcohol. We have them on a CWA protocol to make sure that they don't have seizures. D is the dialogue. So it is a Medicare standard, and that is how hospitals get paid, that we involve our patient into the plan of care. So the D is engaging your patient, making sure that there's goals for the patient knows what those are, and make sure that they know what is going on with them. We're going to do a little activity. Colleen's going to hand out a scenario to you, and as a group, we're going to have you guys do the SVAR and come up with what the situation, the background, the assessment, and the recommendation is for them.
Kind of silly.
You're in a grocery store when you notice a young child running up and down the aisle looking for his mom. You know the child, as he is from your neighborhood. You know that he has some mental disability and has
situation is
Always
Lost
it
child.
has to be one person riding, one
Or
person
found
talking.
child.
Okay. So situation.
He's lost, but he found them.
Yeah. So phrase lost but found.
Found unattended child.
Yes, that's good.
Cause that's pretty much like lost / found.
Child
In grocery store.
in the grocery store.
Can I see it?
Yeah.
Unattended.
Unattended child in the grocery store.
A-I-S-L-E. Grocer.
Yeah.
Okay, found unattended in the grocery store. Background, he said he's from the neighborhood.
I didn't know also he was looking for his mother.
Terrible.
Kind of weird. This is hard to do.
Background, the situation.
And you're right here, yeah. Okay, I know.
So background.
He's from my neighborhood.
He's a flight risk.
Oh yeah, that's a good one.
Flight risk with diminished disabilities.
Shoes and socks all over the floor. Oh, you guys sitting in front of the door, grabbed a girl. The loop.
Yeah. His mother's not gonna sit on it.
We, for background, we also want to explain, kind of as a flight risk up to the situation in context, we just listening.
You could say like, I know this because he's from my neighborhood and he has had a history of disappearing.
Yes. Put background, found him in the aisles, running.
Well, it's kind of like in the front.
I think he makes them laugh.
Assessment.
His mom sucks at taking care of him. I'm just kidding.
And a capability of not to leave home alone.
Wait, what was the first part?
Incapability of knowing not to leave home unattended. Or assessment. And intellectual disability. Safety protocol for mental health.
Another like a recommendation maybe.
I need to find his mother.
I feel like
No,
that's like fixing the
problem. Identification bracelet.
And then I think informing like members of society.
parents would do that, cause that kind of should open up to like kid kindergarten, if you think about it. Identification bracelet, safety devices at home, like, you know, the child lock, door.
Okay, should we say something about finding his mother? When he is currently lost. And then
Okay,
Safety devices,
they're still talking over here. You have it on your poster?
oh no,
Oh, no. Okay, this time, we'll let you get by without doing it on your poster, but from now on, when you do activities, put it on your board so that you can present it. Okay, we will start with the person, red group, yeah?
Yeah, they were the first
We
ones.
did. Luke?
Do you want me to read the situation?
Yeah, 'cause they don't know it.
Just in the sink, shoes and socks all over the floor, and book bags sitting in front of the door. You find your children in front of the TV playing video games. You're reporting to your husband.
Real life. What you gonna do? How are you gonna report this?
So with the situation, you would explain, I'm the wife. You're reporting this to the husband. You're reporting, the situation is the children, you come home and there's a messy house. And then the background, you put the dirty dishes, shoes and socks all over, and the book bag is not put away in front of the door. And then our assessment is, we found the kids are playing video games in front of the TV. And then our recommendation is to take away the TV and have the children pick up their stuff.
This is real life. What else can you do? Right now. Guys, you gotta get your house in order because you are going to go through a heck of a lot in this program. So, I remember when I was in the nursing program, driving to Grand Island and back, and it was the third weekend, and I failed my math test, and people, I know math. I can't spell, but I know math, and I didn't study for it, and I failed it, and I came home and I threw my book bag across the floor, and I said, I quit, and he said, you quit now, you can just find another place to live. But that was telling me he was going to support my decision to be in school. So, right now, you need to be organizing your house. Maybe get those crates that you can buy at Walmart, the box crates, and say, okay, child 1, you put it into this box, child 2, you put your book here, book back here, child 3 here. A safety concern. And then when you get home, you have to, this time, to do your homework. And the TV is not to be turned on until I get home and see that your homework is done. And then I'll turn on TV. I'm a firm believer though, when you're in school and you don't have to work on Saturday morning, teach the kids how to turn on TV, get them to the cartoons so that you can sleep in. That's me. But you are facing this right now. So are you crying and screaming at your husband? No. But you may have to come to Jesus meeting with him so that he knows, you know, you're all in this together. It is not just you in school. It is your whole family that's in school right now. And so there are some things that you can overlook. I remember seeing it was above the TV and it was a cobweb. And I thought, okay, if I start trying to get this cobweb, I'm going to spend all this time cleaning this house. And all I need to do is make sure that it's clean clean enough to be safe for eating and sleeping, and laundry is done, and, you know, do what you need to do. So, my bid is like, you know, get the husband involved, be sure that what's going to happen, because you can't be in school full-time, although I know people that are doing it, and working full-time. Something has to happen, and you don't want to divorce the family, but you do need to think of what can you do. Well, forget the dirty dishes, get out the paper plates for a year, okay? Get a jar that has the snacks so that when the kids come home, they know exactly, these are the snacks, I can have one, and I can have it before we have supper tonight. And this is Sunday afternoon, you make up that you're gonna make up for supper for every day of the week. Put them in the freezer so it's easy to pull out and put in the microwave or heat up or whatever. Get organized, people, because it's easy. I think you might have felt overwhelmed this week, but this was an easy week compared to what you're gonna be putting up with. I'm sorry, right? I have my master's degree, I have a degree in biology, I've taken a whole bunch of those science classes, those kind of things, and to my grave, I will say the hardest thing that I ever did was the nursing program. Your trick might not be the same as yours, because you have 3 kids and you have 2?
0.
0. She only has a cat.
A cat, a dog, a rabbit, and fish.
Oh, see? Yeah. And I think husbands sometimes count double. So, but they need to know what the ultimate goal is. You know, here. And you may have to find a different place to study. I know students, and they used to go, it was Country Kitchen, and that's no longer here. But they found a safe place where they could go and really look at their stuff, you know, away from the house. So, okay, red group.
You are stuck in traffic. You are late getting to work related to this uncharacteristic traffic. You are not regularly late to work. You are reporting to your supervisor who's expecting you at work. So we put for the S that we're stuck in traffic, the situation. And then for the background, we put that she's not regularly late to work. And then for the assessment, we said that she might have come upon an accident. And then for the recommendation, recommend that she leaves for work earlier.
Okay, people, are you dealing with that right now? Being here at 8 o'clock and having Kearney Regional over there and the high school over there? Okay, traffic is horrendous. So, find an alternate way to get here. 2, leave earlier. 3, call your instructor to say, I had a flat tire, I'm on my way, but I had a flat tire. Keep in communication. Now, the problem is that if you have hit a deer, and that's why you're late every single day of class. It's like having 100 grandmas that have died and you're calling in to go to the funeral. We're not gonna believe you, okay? So you have to make an effort, we have to make an effort as well, okay, to be here on time. So, and I don't like the traffic here. So, and I come from the south, so I'm hitting people coming in through town. Okay, so make it work as a student. You guys.
You're in a grocery store when you notice a young child running up and down the aisle looking for his mom. You know the child as he is from your neighborhood. You know that he has some mental disability and has left home unattended in the past. You're reporting to the grocery store employee.
So for a situation, we found an unattended child in the grocery store aisle looking for his mother. For background, he's a flight risk with diminished disabilities. He's from my neighborhood and has a history of leaving home unattended. For assessment, he is incapable of knowing that he's not allowed to leave the house due to his disability. And for recommendation, we would call mother and then maybe recommend getting like an identification bracelet in the future.
So, what would be a good thing? This has a mental disability. Would you grab that child?
No.
No. You need to get down on their level and talk to them and keep them calm, because if you scare that child, he may actually run out the door of the grocery store and get hit by a car. So you always have to think of who you're talking to and how to get the situation under control. But I would not let that child leave until we find his mother, whether she's in the store or whether she's home. You know, he needs to be cared for. And so finish up that care of that patient. So the only thing I noticed, and we didn't even talk about this in the class, when you go up to that grocery store guy and say F, da 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 da, B, da 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 da, A, da 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 da, R. No, but you can use that S bar or I shape to organize your process, to really have a one-on-one with that grocery store, individual. You wouldn't be saying S, B, A, R. The husband that you gotta talk to, yeah, they'll blow that off. This is the one with the kids. Okay, that one with the nurses and the instructors, you might be able, well, here's the situation. And this is where I'm coming from. My babysitter didn't get there so that I couldn't get out the door fast enough. But this is what I'm looking at, An instructor might not understand this far, but the others. Can we keep on going, or do you guys need a break? Okay, we're going. Okay. Okay, the next thing we're going to go over is health and illness. Now, I'm only giving you one sheet of paper so that you can share, so everybody gets where you can see what I'm going to be going over. Okay, the first one I'm going to go over is bubble one. The bubble one is in your lifespan one textbook. I have an old textbook, I don't have a new one, so my page number is 407, and yours might be just a little bit different, but it's around the 400 page mark, okay? 407. Now, this is telling me that when I look at a patient, I need to consider a whole bunch of things about that patient. One, I need to look at the environment of the patient. Where does he come from? Is he a homeless man? Is he a person that lives in the dorm and he has 3 suite mates with him, and they're all going out and partying? Do they live in a home where there is a grandmother and children and grandchildren? So there is like 4 generations in that environment. So what kind of environment is he in? Is he in a nursing home where there's 2 residents to every room? So that means they're in a crowded area. Environment. Occupation. What do they do? Are they retired or are they not retired? Did they work in a sawmill and now they have respiratory illness? Is this a person that works in a daycare? And with the daycare, what do you expect? They are going to be coming in contact with a lot of sniffly noses and fevers and those kind of things, cranky kids. You know, did they come in contact with? So their occupation. You look at their intelligence, you know, are they going to understand that they need health care? Can they understand instructions? You know, we have a lot of these same-day surgery places popping up all over the place. And the thing with same-day surgeries is that that person has to be responsible for their own care when they go home. Can they understand the instructions that now that they have back surgery, how much can they move, you know, when they get home? Or how is their environment that they have to walk up 5-foot flights of stairs to get into their house? You know, what is their intelligence that they can understand those instructions? And how you work with a child is going to be different than how you work with a college graduate versus somebody that has dementia. You know, how you're going to work with that. Spirituality, I really see that is a need of the elderly person. It should be a need for everyone, but I don't see so many of the young adults having that spiritual need to go to church. But you may be working with someone that is dying and you don't know what to do. In fact, I had a person come out and he said, we need somebody to pray with us. And so knowing the family, I went in and did that. But people, you can always pick up the Bible that's in every single room and flip it over to right in the middle and you get Psalm 23 and read that. Even though you may or may not believe in what it says, it is soothing to that individual that some individuals that are dying. And not everybody needs that. I think everybody should, but I mean, you know, you don't push religion on anybody. Okay. How is that physical being? We look at that physical being. Maybe this person looks fine, says they're fine, but they have a chronic illness such as diabetes or respiratory or something. So what's going on that would affect their level of wellness. Their emotional state, how they are emotionally, are they able to handle or cope with difficulties in their life, and how do they cope with those difficulties? And social, what do they do? Is this a person that is on drugs, go to the bars, does have family support? Because I see some families move into Kearney and there's not a grandma or a grandpa around to help them out. And so they don't belong to a church. Well, who are they relying on to give them support, you know, when they are ill? To help out when they have to have surgery or whatever. There's no one there to help them. So all of those things are things that you need to consider on placing a patient on a illness, wellness continuum. Illness, wellness continuum. It used to be called health and illness continuum, where you would start with the numbering for health at a 0 and go to illness, which was a 10. It's the other way around. So now in your book, and this was on page 407 of your book, is the illness wellness continuum. Because we want to make sure that we get the patient all the way over here to be at a high level of wellness. But I will tell you that there are some patients that you can never get over there because their home environment, their chronic illnesses, their emotional status, they have a lack of support system, and they can never be over here. So, this is what is in the book. This other part, I'm not giving it to you, but I will tell you that you can go online and look up Illness Wellness Continuum, and you can print out something like this that will give you some clues on where you want to place your patient. Okay, are you all with me? I first want you to think about what number are you? I would tell you that looking at you, you could all have been 10s. But now that you're in nursing school, do you think you're still a 10? No. The stress of what you're going to be going through has gone down a little bit. And I don't know if you have a chronic illness or diabetic or whatever. And I don't know your support system, but you all probably would identify yourself in a different place on this illness, wellness continuum. And I think you're probably going to go down a little bit because I bet you, as a student, you're not going to be eating right. You're not going to be exercising like you should. Okay? You're going to have the stress of what you have to do in your home life or whatever. And so what we want you to do is to keep on that good high end and not drop down too far. Okay? But at the hospital, you will be assigned a patient to care for. And in your reports, whether it's on your nursing care plan or whether it is on your case study that you're doing for your patient and presenting it to somebody, you have to identify where that patient is on this health illness continuum. And the very first thing you're going to do is ask that patient to place himself on a scale from 0 to 10. So I'm giving you 4 case scenarios, 1, 2, 3, 4. So I want you to put 1, 2, 3, 4 on your board. I want you to read this with your little group. I want you to identify where you would place this patient, which probably or may be different than how they place themselves. Okay, I think I'm losing them a little bit.
A 36-year-old woman, obese, has diabetes for 4 years, has been on all hypoglycemic meds and starting on injections.
No, injections. It should be injections of insulin, not injections.
Work as an administrative assistant, married with a 10 and 8-year-old. She places herself at a number 5 on the health illness continuum.
I would put her lower.
Yeah, because now that she's starting with diabetes.
Positive attitude.
And she's got kids.
Huh? Yeah, 10 and 8, and she's working full time. I'm gonna assume so. And she's married, so that's really stressful. Married, kids, diabetes.
So she said she was at a 4?
She was
She
5.
said she was at a 5, but remember, she's obese too, so that means she doesn't really take good self-care for herself.
And then she's
And
doing
then-
like the drug therapy stuff. She's taking.
Yeah, she was taking the meds, but obviously with her obesity, she hasn't done anything with it, because if you're on meds, there's so chance.
Yeah. So what, like a 2 or a 3?
Yeah. It's something like a 3.
Yeah.
So who's the one that we're like?
20-year-old male student on a football team has several girlfriends. STD walking. Come to the hospital for her an uncomplicated epiphany. He places himself at a 5 off. He's at high risk, dude. Did he have it out of 5? So he's on the football team, so you know he has sports injuries, possibly concussions in the past, has several girlfriends, so you're collegeable. I doubt he's thinking protection. Uncomplicated, and he just had surgery, so he's still at risk. Even though it was a fine surgery, he's still at risk for an infection.
He put himself this far?
Yeah.
What, maybe Cause he's still, he's working out, so he's probably eating good.
Concussions.
But yeah,
Concussions a leading thing for football.
Whatever it says is what it says.
'cause we don't know for sure that he's not using protection and all that.
Yeah, they could just be like girlfriends.
Yeah.
Friends.
Well, you can still get your even not sexually.
I would say friend, cause he's not as bad as the other lady, he only put her at 3.
Yeah, he's way better than the other.
Cause he's not
You should
open.
actually, you guys should read into football injuries.
No, I know they're bad, but at the same time,
Yeah, like he's still healthy. He can bring it up. He's got no
Well, not
kids.
right now, he just had a trauma to his body, he had surgery.
Yeah, but that's not as bad as like
A surgery?
diabetes.
When you have surgery, you just,
but
you would just cut open.
technically he's not gonna be like out of it forever.
No, but if he doesn't stay, he came to the hospital. Well, it doesn't say when he had it, so that could be just history. So yeah, I put him on 4 because I don't know more about the surgery. 10-year-old, fractured right hip, bike accident, vital signs are stable, crying and lot of pain, going to surgery day, up to date on immunizations, mother is not in, father's a truck driver, and is gone most of the week, mother places him in number 1 on the health list. Of course the mom's gone. Doesn't have much support, dad's gone, mom's not in, so you know a nurse's schedule. Waist up today on surgery, going into surgery today, in pain, vital signs.
so like a 1 or 2.
No, they're not that bad.
No big deal. Going into surgery too.
I would say a 2 or 3 just because she is stable, vital signs are all stable, she just has a lot of pain. She has a fractured right hip, right tibia, not tibia, it's just a fracture. And remember, Tina doesn't have no pain. So I put out a 2 or 3. Because a 1 is like they're near death. 75 male history of COPD and CHF, smokes 2 packs a day for the last 50 years, retired factory worker, wife died. 2000, lung cancer, has come to the ER 6 days ago, fever, cough, and lethargic. Today he is better, breathing, and be dismissed. He puts himself on a pod.
So is Cindy
He's lower than that.
Yeah,
Oh,
she works at Flat Valley.
It's gotta be like,
He just came in for a fever and a cough from the ER. There's no one taking care of him. He's not
Nurse.
too
he's
passive
smoking
behavior
all the time.
for the last 50 years, and he has COPD and he hasn't stopped.
Get all the patient charts ready.
One?
Information into
And he's 75.
She said, I'm just too old.
I'm trying to figure out how old she is.
When she first tested about it, because I just always known her to work on the floor and things like that. I was like, "You sure you don't like that?" And she was like, "No, just too old to do that."
Okay, we're done. Okay, so, group 1, blue group. Read about, tell me where you placed them, and what did you take into consideration when you placed them. So everybody knows that this is the 30 36-year-old woman with diabetes.
You want me to read the scenario or I
You
can?
can,
just say-
sure.
Okay. So the 36-year-old woman, obese, has diabetes times 4 years, has been on oral hypoglycemic meds and now starting on injections of insulin. Works as an administrative assistant, married with a 10 and 8-year-old. She places herself at a 5 on the health wellness continuum. And we placed her at a 3 because her diabetes is getting less controlled. She's now needing to start on injections of insulin. And we feel that she probably has some stress in her life with her job and having children at home and managing her illness.
Okay, so you said 3, what did you guys say? 2? She's near death. How did you say?
3.
3? We actually said 4, okay? Because she can get it together, but what would you teach her to get her life healthier?
Self-care.
Okay, going to healthcare, but what does she need to do to get herself healthier?
Control her blood sugars. So
How is she gonna control her blood sugar? Diet, exercise, compliance with her medicine. So, do you think she has an occupation that is conducive to increasing her health, improving her health?
No.
No, because she's an administrative assistant and she's probably sitting at the desk. So she needs to think about, okay, if I do have to keep this job, what can I do? Every 10 minutes, every 10 minutes out of the hour, get up and move around or do some standing things, computers that stand, eating right, setting up an exercise program. So, yeah, we would say a 3 or a 4. Probably a 4. 1, they're getting close to dying. 0, they're dead. 1, it's a touch and go. It can happen anytime. 2, it's almost that way. And she probably will not just die today. So 3 or 4 is why we would place her in a little bit different. And people, we're all learning. This morning we got a whole bunch of different numbers. So anyway, so it leads for discussion. Okay, red group.
20-year-old male college student on the football team has several girlfriends. Came to the hospital for an uncomplicated appendectomy. He places himself at a number 5 on the health and wellness illness continuum. We put a 7 because he's, pretty healthy other than just having to have an uncomplicated appendectomy, other than his mental state with his girlfriends.
Yeah, and you don't know where that's going,
Yeah.
do ya? So, but he has a support system.
Oh, yeah. Yeah.
Yeah.
A girl from a girl from Monday, a girl for Tuesday.
Could there be some drama with that? Now, why do you think he put himself at the 5?
I think it'd be sad because he has so many girlfriends. I don't know.
Probably doesn't know which
I
one to
think
tell.
Probably because you have to take time for football.
Yeah,
For
and
recovery.
sometimes he doesn't think about the whole realm of life. Hey, you know what? Appendectomy, you're gonna recover. If they diagnose you with cancer, you may not. Okay, so he's much higher. He's strong and healthy, and he can recoup and have more girlfriends if he wants. So, okay. So what did you put him at?
4.
4. So he's really sick, or on the sicker end.
Well, I was reading more into it. Just
Bingo.
because-
You were thinking he already had an STD, right?
That football player, leading thing for them is concussion. So he's probably had past injuries, longer to recover.
Okay, so what did she just do? She read too much into the story. And that's something that when you were taking tests, people, just answer the facts of right now. What is the act?
Yeah, when you take your boards, that's how it is, and if you read into it, you're gonna miss every question. Read what they have there and don't assume anything.
And what did you guys put him at?
6.
Out of 6. Okay. We actually put him at a 9. Because if he's a football player, he has been on a regimen, probably eating properly, strong. This is just gonna have him have a step back to recover, and then he's gonna be out doing things again. Okay? Okay. And he doesn't have an STD yet. So, okay, number 3.
10-year-old fractured right hip, bike automobile accident, vital signs are stable, crying and a lot of pain, going to surgery today, up to date on immunizations, mother is an RN, father's a truck driver, and gone most of the week. Mother places him at a 1 on the health wellness.
Okay, where did you put him?
A 3.
A 3. Okay, what did you put him at?
2.
2. Where did you put him at?
5.
Okay. Now, looking at that, he does have an injury. He is going to surgery. But it sounds like he has pretty good health. His mom's in tune to his needs and has gotten him on all the immunizations that he needs, and she's there. One of the things is that his dad is not, but maybe he'll stay home more. I'm reading something into it that I shouldn't. But we actually put him at a 9 because he is 10 years old. He has a broken bone. He probably won't have a broken bone the rest of his life. Okay. Now, why did the mom that's an RN put him on a 1?
Because she's a mom.
Could be, but they also, if you heard me say this already, it used to be the scale was health, illness. And this is illness, health. So anything from 5 going down, you're going downhill. Okay? Your condition is getting worse. If you are of good health, you should be probably 5 up to 10. Okay? A setback from 10 would be that you have an injury and you're going to surgery. So what that means is that when you are a nurse and you are asking a person on a scale from 1 to 10, where would you place yourself? You need to say something else. 0 being extreme or close to death, and 10 being the utmost health. Where would you place yourself on this continuum? So I threw that in there because even though she's an RN, she's on the wrong scale. And you've got to get her educated on the right scale. Okay? Okay. Trick question. I know. Okay, I'll read the next one. 75-year-old male, history of COPD, congestive heart failure. So COPD is chronic obstructive pulmonary disease, like emphysema, asthma, and chronic bronchitis all rolled up together. And congestive heart failure, his heart it's a poop pump, and it's not working well enough to pump the fluid or blood through. He still smokes 2 packs a day and has for the last 50 years. He's a retired factory worker. His wife died in 2000 of lung cancer. He came through ER 6 days ago with a fever, cough, and lethargy, which means he's kind of out of it and hard to respond. He places himself at today he's breathing better and being dismissed. He places himself at a 5 on the health wellness continuum. Okay, you guys, where do you think he should be? 3. You guys,
1.
1. Where do you think he is?
2.
Oh, 1, 2, 3. We actually put him at a 1 to 2, okay, because he has a chronic illness. It's affecting his heart and his lungs, and he is never going to recover from this. He doesn't have a support system, doesn't say anything about family, but his wife is already dead. And still keeps up the poor habits of smoking. So he's on the lower end of the scale. Okay, so has this been helpful to understand this a little bit more than just reading it out of the book? I hope.
So my question is, when we're looking at these, we're not looking at like that short-term picture, like you're in the hospital, you just had surgery. We're looking at your overall wellness of your overall, like the 10-year-old, because surgery could go horrible, which is reading into it, I understand, I'm just trying to process it. So surgery could have complications and then you could be moved down a little bit more from your 10, but we're talking, if you are normally healthy, you're starting at a 10, and then we're just gonna count you back just a little bit if you have something that's come up. Am I understanding that right?
Mm-hmm.
Okay,
You got it.
thank you.
Mm-hmm.
Because I think when I first looked at it, I was looking at it like, okay, so right now in this situation, if you came into the hospital and you're having surgery, I wouldn't put you at a very great level because you're now here to have surgery, so.
I was looking at it from the neutral point.
This, femur that's broken, and he had to have surgery, and he developed a compartment syndrome, which is a complication of a fracture, and then he ends up losing his leg. His placement on here is definitely going to change.
Okay.
But the word is illness, health, continuum. So the continuum part tells me I'm looking at all of those factors right there. His support system, his home environment, his physical, and I think too many times as young student nurses, and maybe old ones too, that we only look at the physical and we don't look at the big picture of what's going on with that patient. You know, this 75-year-old, he's not going to make it many more years if he continues with this habit. But if I had him, and I said that he no longer smokes. He smoked for 30 years and has stopped smoking 20 years ago. If his wife is still there, then I probably wouldn't have him at a 1 or 2. I might have him at a 3. And, you know, he could have come in to the hospital almost dying. I mean, with COPD and congestive heart failure, one little infection and they're gone. Okay? So, yes, right now, people, you don't know those medical diagnoses and how the long-term effects are. But it's something to look at, but it's not the only thing to look at. You have to look at all those bubble things. So, we are going to talk about vital signs for a little bit. And I have a feeling nobody wants to stay in practice, but we might have a little bit of time to practice. So, did you learn anything today? What did you learn? I'll pick out one. Loretta, what did you learn today?
Taking care of patients, you should consider when you're charting something, you can consider SBAR to go off of that.
Okay, you can use SBAR to communicate what's going on with your patient to the other nurses and when you're reporting on. Okay, Mackenzie, what did you learn today?
HIPAA is a huge thing.
HIPAA is huge. Yes. And as old as we are as nurses have to still be very mindful of this. Okay, then, I'm trying to think. I thought you two look alike, and so I'm not going to have trouble with it. But you have the name of somebody that, okay, what's your name? Leanne. What? Leanne. Leanne, yeah, you don't look like any of the Leannes that I know. But Leanne, what did you learn today?
I really like the I-shaped thing for bedside report. I think the way it's laid out is like very easy to follow and you can check off everything that needs to be checked off. And give
Okay.
a good report to the next nurse coming on.
So the reason why you got copies of that is utilize that when you go to the hospital. Because never go up to your primary care nurse and you're reporting off at the end of the day and you say, what do you want to know about this patient? No, you handle the situation. Because she has 5 patients, you have 1, you've got to make sure that she's receiving the report on the right patient. So you use your S-bar or your I-shape. And you're right, I-shape might be a little bit more complete. Basically, you're giving a good report. Okay, thank you for telling us that. Okay, Melissa.
All right. So, blood pressure cuff. When you have a patient that is real tiny, you need to have the right cuff. Or someone who's real big, putting this cuff on there is going to give you false blood pressure measurement. So when you hold this up to them, you should have on each side a little bit of room if you're measuring this. So this would be a good cuff for her. Colleen and I do the same thing when we were taking blood pressures. I hold their hand here with my elbow so that I have both hands so I can put this cuff on her easily. Make sure that your artery thing is pointing there, and then you can get that on there nice and snug. Holding this in your hand, when you turn it right, we had some students earlier that were playing with it. Right is to make it tight so that you can pump it up. Left lets all the air out. Don't let your air out too fast or you're going to miss your blood pressure. And don't try to put a cuff on a patient with their arm is right here. Okay? You can scratch them. For females, if they could, you're touching them inappropriately. So make sure that you're grabbing their arm. We monitor how you are scored in our lab is based off of, do you know how to do the skillet? That's easy enough. We can check you off on that. We watch to make sure you're caring. So how am I going to know if you're caring or not?
How you talk to the patient,
How you interact, how you touch them. If I grab Mackenzie's arm, put the blood pressure cuff on, and just let it drop, is that very scary? No. So once you get the cuff on, lay their arm back down and take the blood pressure. Your stethoscopes have 2 sides to them. The first side here is called the diaphragm, and the other side is called the bell. The bell listens to lower tones, so you can turn this to make it on whichever side that you're trying to listen to. When you're taking blood pressures, don't put your finger over the bell. You want to be on each side of the thing, or each side of the diaphragm, so you're not picking up your own pulse when you're listening to the blood pressure. One student brought up a stethoscope to me in the last class, and hers actually shuts off. So you can turn it either way, but if it's like sideways, it's off. So she's like, I can't hear anything. And so I had to show her how to do that. Your ears, this is what I refer to as your ears. Make sure that this part goes into your ears like this. Okay? Not to the back of your ears. It needs to go into your ear canal. Taking a temperature. You've all seen that nurse that says, here, open your mouth, and they just let it go, and then it's flopping all over the place, and takes 30 minutes to get a temperature on your patient. If you hold it there, it's a lot easier to get your temperature a lot quicker. On here, the little guide, if you push this little guide, it will give you a different method of taking temperature. So it comes on oral. If you click it again, it goes to axillary. If you click it again, it's the little guy. Okay. O2. This one here shows you which side is up or down. On some of them, I know at Penny Regional, the cord has to be up for them to monitor. This one, it's showing you to put your finger in this way. So if you're not getting a good reading, like maybe the patient's hands are cold, warming their hands up to get a good O2 reading on them sometimes helps. And there's also other methods that you can use. Like they have forehead O2 sensors. We have ear ones, so you can use different methods for getting an O2 stat. Pauline, what am I forgetting?
I think you got it. How to take the pulse.
Oh, yes.
Pulse.
So, taking what we're going to be monitoring for you guys first, we're going to check out my skills next week. So what we are going to watch for is that you're doing a pulse. For how long are you supposed to do it for? A whole minute. We're going to watch you do it for 30 seconds because we have so many of this to check off, and so it takes too long. And we're also going to watch you listen to respirations for 30 seconds. How long would you listen if you were listening to a real patient? A whole minute. When you are listening to the apical pulse, you should be listening and feeling the radial pulse at the same time. It is easier if you hold their arm down because then you get a little more pressure from the radius to push down on that artery. But listening to make sure that my heart beat is the same as the beat that I'm feeling in my hand. If it's not, they're probably in some arrhythmia. It's probably going to be AFib, would be my guess. So make sure you're listening and feeling at the same time when you are doing the apical pulse.
Okay, so go over there, grab, talk about how to put the tympanic in.
Oh, the tympanic one. When you're doing a tympanic temperature, I've seen people just shove it in. First of all, it hurts. Secondly, what are they going to do? Move. They're going to move because it hurts. I am, Mackenzie kind of knows me. As a whole person, I am not a very touchy-feely, like, I don't want you to come up to me and give me hugs and stuff like that. But when I'm caring for patients, I use both my hands so that I can keep track of them. So if I go to put this in her ear and she moves, what am I going to do with her? Move. She moves, move that way. I can move with her, okay? When you put this in her ear, how do I hold her ear? Up and down. Up and down. Then you're going to want to go into the canal, like kind of like a cell phone. When you hold your phone to your ear, you kind of go in at an angle like this. And use your fingers to hold it here, and then hold her. If she moves, you can move with her. Okay?
Jump up, grab blood pressure cuff, and take at least one blood pressure on each other. Okay?
Get that cup. Here we are. All right. Perfect. What's somebody else? It's weird that we're supposed to grab like that. Yeah. Huh? That's enough. That's not good. She throws around in her bag.
Oh, I thought you were another student. I hope you didn't get here.
No, just me. Does it fit you? Well, it doesn't matter. It's the only one. How long it's been for?
Also, if you have like a
started hearing it and then. Just for extra as many times as you want.
Can go down just a little bit, thank you.
122 over there. Nice. You're pretty nice. It looks like a middle row. Right now. I didn't know I was supposed to go that way. Who's the other one? Yeah.
Yeah. Okay, so like, what do you
I think it's so weird. No. Let me write down your vitals.
There you go.
You didn't chart it. Okay, mine's really low, okay? Unless I'm too nervous.
The palpable method and the listening.
I just wanna make sure that you get it right.
Okay, I'm just.
Okay, this blood pressure stuff, I mean, your vital signs, you can pass fail. We expect you to be able to do it right. It is in the lab, the lab book, so read over that procedure. And we may ask you, okay, this is the child, how should we take that, temperature? And if we were taking an axillary temp, we would use, make sure that you push on the button to get it to a child on here, okay? And we wouldn't be using the tympanic, of course, if you're doing an axillary temp. So we may be asking questions of you as you're doing it that would be straight out of the book. Okay? So, and we might ask you, okay, on this person, what size of blood pressure cuff would you use? Does it process a lifespan? So we're not dwelling on it because you've already learned that skill. We want to make sure that you are doing it right. Okay?
Is this an adult one?
Did anybody have fun tonight? Today?
Did we what?
I hope you had fun with learning today. And I hope it meant something to you. So,
Didn't get to
terrific. Okay. And you can leave when you get done.
Jamie, what's next? Do you have bags that go down here?
I want
No, you can just throw it in there.
yeah, just have a girls' weekend.
Okay. Are these just like the swimming?
These are low fidelity where in Grand Island they are high. I still can adjust the blood pressure. I can change the breathing. I can change the rate. I can have them taller, you know, and so we will be doing that more and more throughout the semester, especially with lung sounds where it's real hard to hear. We also have Mr. Chester, who's a chef, and Mr. Chester, and we're going to Chester out and even turn